hip case and a short case.
Yeah, good morning. I'm Dr. Rishi Agarwal. I'm from KEM Hospital. I'm a third year resident there, and I'll be presenting a case of the hip. It's a long case. Good morning, sirs and ma'am. Ma'am, my case, this is a 4-year-old female child. She's a resident of Goregaon. She has come with the informant being mother. She has come with the complaints of a limp since the past 2.5 years and a swelling that was noticed in the right hip region by the mother 6 months back while tending to her hygiene cares. So the child was apparently alright 2.5 years back when she started walking at the age of 1.5 years. So ever since the child started walking, the parents have noticed a limp, which has been progressive, and they've noticed that it has increased in the past 6 months, and it's not associated with any pain. The mother has also noticed a swelling in the right hip that is hard in consistency, she says, but it's not increasing in any size, and that's it, ma'am. Not associated with any pain again. And there's no history of fever, there's no history of tuberculosis or tuberculosis contact, and there's no history of any other hospital admission or any procedure done on the child. The child was a preterm hospital cesarean section, and she was admitted in the NICU for 1 month post delivery. The indication for which was probably a maternal indication because the mother gives history of her blood pressure being raised during the time. She is the first of 2 children, and there is no family history of a similar problem in the patient.
Any idea about what the presentation was? Was it a vertex or a breech presentation? If the mother know.
Ma'am, the mother says that she wasn't informed about any history of the child being in any other way than she should have been.
Have you asked about this?
Yes, ma'am. Yeah. I've asked her. They said that the baby is normal, but because the blood pressure is raised, not because the child is upside down.
There is an important history. You can ask the mother when the pre-antenatal ultrasound is done, whether she was informed that the breech is there or vertex, because we know that breech presentation leads to increased risk for DDH.
Yes, ma'am.
The other important history is the NICU stay. Yes. You said for 1 month. So what was the indication for that? Was there anything?
Sir,
so the parents usually know exactly what, or at least generally what had happened.
Sir, I had prodded for this history. They said that there was no fever or nothing other than that was done, but it was probably because she was a preterm delivery that she had stayed in the NICU.
How preterm was she?
So she was 8 months, the mother said.
In the context of the present case, how is a history of NICU stay important?
Sir, I would, if the NICU stay the child could be suffering from some syndromes that require NICU stay.
Anything else? You asked about history of fever.
Sir, it could also be a neonatal sepsis that had probably led to a septic focus in the hip that has led to destruction of the hip that would present in a similar manner.
So this happens many times, that there is a history of NICU stay. The child has had hip sepsis at that point of time, which was missed, okay, because of the general condition of the child, and then the child presents at a later date with such a picture.
Yes.
Go on.
So the reason why we are asking is that 8 months a preterm child is not very preterm. So there has to be some other reason for the child being admitted for a month when the child was 8 months of gestation, right? So it can be a neonatal sepsis which was disseminated, and she had a septic focus of the hip, right? So that is one possibility which we always have to entertain.
Yes, sir.
Yeah.
So there's no history of a similar complaint in any of the family members, and in the other sibling as well. Sir, I'll proceed to examination.
Any other thing, like she's been diagnosed at a very late age, okay, and dislocation is a thing. Once the child starts walking, it is going to be evident. So any reason whether the parents have not sought any treatment, or have you asked anything?
They just gave a history that she used to walk a little differently, but they were ignoring it. But since the past 6 months, it has become more prominent. So that's why they've sought treatment at this age.
Because that is little unusual for DDH sort of thing, if it was something, a post-septic sequelae which is now progressing or some. So again, go into the detail of the history, okay?
So, ma'am, should I proceed with the examination? On
No
general
treatment taken till now. This is the
no,
first
no
time they have
treatment taken
presented.
prior to this, ma'am.
Okay.
Ma'am, the child is, the general condition of the child is fair. She's averagely built and nourished. And ma'am, there is no pallor icterus cyanosis, lymphadenopathy or edema. And ma'am, the child was examined in the standing, sitting and supine position from exposed below the nipples. So in the standing position, we noticed that the shoulders are at the same level, the nipples are at the same level. The right-sided anterosuperior iliac spine is at a lower level than the left-sided anterosuperior iliac spine. The patella are at the same level and both the medial malleoli are at the same level. And in the lying down position, the shoulders and the nipples are at the same level. The anterosuperior iliac spines are at the same level, with the right knee being at a higher level and the medial malleolus being at a higher level than the left side. On inspection, so the attitude of the child lies with the hips extended, knees slightly flexed, foot slightly dorsiflexed in external rotation. There is no scars or sinuses over the
Why
region.
the foot is dorsiflexed?
Ma'am, sorry, plantar flexed, ma'am. I
Foot is
misspoke.
never
No, ma'am,
dorsiflexed.
I misspoke. There is no swelling that can be appreciated from the front, but when examined from behind, there is a swelling in the gluteal region. And there is no wasting of the thigh muscles, but there is a wasting of the gluteal muscles that is seen. The right-sided gluteal fold appears to be at a higher level than the left side, and that's it on inspection. On palpation, the inspectory findings were confirmed. A hard globular mass is felt in the gluteal region that's around 3 into 3 into 3 centimeters in size, and it's moving.
What do you feel this hard,
Sir,
bony swelling is?
Sir, I would like to think that this is the femoral head that has dislocated.
Do you feel a humeral head would be felt in the gluteal region?
Femoral head, sir.
Femoral head would be felt in the gluteal region.
Yes, sir. If it has dislocated, I would expect to feel it in the gluteal region, and I would expect to feel the greater trochanter on the lateral aspect of the thigh.
Okay, if we assume that this is a DDH, what is the normal direction in which the femoral head dislocates in a DDH?
Sir, the femoral head dislocates in the anterolateral. The dislocation is anterolateral, sir.
So, do you expect to feel it in the gluteal region?
Yeah, sir, it would dislocate in the it would dislocate anterolaterally, but it would move proximally, migrate proximally and behind.
Can you palpate the lateral aspect of the shaft?
Yes, sir.
So go ahead and ask the mom where she is able to.
So it's on that side, sir.
So you feel this.
So that's.
So this is the GT. Where is the other bump which you are feeling? Is this moving with the Isn't that the issue, tuberosity?
The velocity I found a little lower, sir.
So, एक मिनट हाँ बेटा. So, head feel होता है ना तुम्हारा? ये feel करो. है ना हाँ. Okay. So if you see the lateral aspect of the shaft, that is what she is feeling.
The greater.
It's given in books that there can be a hard globular mass which is felt, but typically I felt that it is slightly not scientific, because usually it is an anteverted femoral proximal femur, and the anteverted proximal femur usually we see anteriorly here, right? So so the bony mass which is usually felt is that of the high riding GT usually, right? So that's what usually it is, right? What?
Yes, sir. So on palpating, the right-sided greater trochanter is more prominent, and but there is no tenderness over it. Sir, on palpation, I also was able to check the Galeazzi sign was seen, sir, where the right-sided femur, there appears to be a shortening in the right-sided femur. The right side, when seeing from the right-hand side of the patient, I found that the knee is at a lower level than the left knee. But when seeing from the front, the knees were at the same level. So which suggests that it is a femoral shortening.
Okay. Go ahead.
Sir, the special tests that I have done for this child are the Trendelenburg test, which I found positive for the right
What
side.
about movement, measurement? Then comes the special test.
Okay,
So your inspection, palpation, movement, measurement, and then any of the special tests.
yes, ma'am. So,
How
ma'am,
are the movements? What is the measurement?
yes, ma'am. So, ma'am, on movements, the flexion is 130 degrees on both sides. The extension is 15 degrees on both sides. On the right side, the adduction is 30 degrees, and the adduction is 40 degrees, and the abduction is 30 degrees. On the left side, the adduction and abduction are both 40 degrees. And the internal rotation on the right side is 30 degrees compared to 40 degrees on the left side, and the external rotation is 40 degrees on both sides.
So abduction, internal rotation is restricted on the affected
Ma'am,
side.
the abduction is slightly restricted, but the internal rotation is 10 degrees more.
Internal rotation is more.
Yes.
You said 30 degrees and 40 degrees.
Sorry, sir. It's 40 degrees on the right side and 30 degrees on the left side.
Okay, it is only 40 degrees.
Yes, only 40 degrees.
Okay.
How do you check the movements? Show me how do you check the hip movement? Demonstrate how do you check for hip movements?
Sir, I will check it on the normal side first, and I will stabilize. I have marked a point at the center of the hip. So this is 40, this must be 40 to 50 degrees.
40 to 50 or even more. How much do you think it is? So, how much do you think it is?
So this would be around 60 degrees, and this is 30 to 40 degrees.
Correct. Right? And how much do you think this is? How much do you think this is? Again,
About 70
70
degrees.
degrees. Right? 1 minute, beta. 1 minute, 1 minute. And this is equal to the other side. Right? So, internal rotation is almost 60-70 degrees in this case. Right? So, so Rishi, always, as I told the previous person also, there has to be some thought given to what findings you are saying, right? You are saying just 30 or 40 degrees of internal rotation. We also have 30 or 40 degrees of internal rotation. Logically, if you are thinking of an unstable hip which is lying out of the acetabulum, the internal rotation as well as external rotation, usually it's going to be more. Right? It can't be just 30 or 40 degrees.
Yes, sir.
Right? In this case, almost 60 or 70 degrees of internal rotation. Internal rotation especially is going to be more. Right? So it's almost 70 degrees of internal rotation in this case. Right?
Yes, sir.
So then, next, abduction is restricted.
Abduction is restricted, sir.
Okay. Anything else?
So I'll go to the measurements.
Okay.
So I found an apparent shortening of 1 centimeters, 1.5 centimeters, and a true shortening of 1.5 centimeters. And sir, on the Bryant's, I drew the Bryant's triangle, where the base of the triangle was 2.5 centimeters on the right side and 4 centimeters on the left side. So I confirm that the shortening is supratrochanteric. And on the Nellitins line, I found the greater trochanter to be at a higher level than the Nellitins line.
Why do you have apparent shortening in this particular case?
Sir, because the child is lying with the limbs parallel, so the true shortening is being seen as the shortening in the apparent length also. There's no difference.
No, come again, can you explain?
So with
You said there is an apparent shortening of 1.5 and a true shortening of 1.5.
Sir, the apparent length is 1.5 centimeters less on the right side as compared to the left side, and the true length is also 1.5 centimeters less compared to the left side, sir.
Both ASIs are at the same level or at a different level?
Ma'am, at the same level.
Okay.
So there is a true shortening, right? How is there an apparent shortening? An apparent shortening would come in only if there is a abduction or adduction contraction.
Yes, sir.
So does he have an abduction or adduction contraction?
No, sir, she does not have any
So
contractions.
would you have an apparent shortening here?
It's a true shortening of 1.5 centimeters.
Go ahead.
So that's it, sir. So the special tests that I've been able to elicit are, I found telescopy to be positive on the right side, and Trendelenburg's test has been positive on the right side, sir.
How, can you demonstrate how do you do the Trendelenburg test?
Yes, ma'am. So, ma'am, I'll just demonstrate from that side so it's easier for the camera. So, yeah. So, I'll have the child stand and examine
जरा
the
तिला
child.
उभं करता जरा
बैठा
प्लीज
दीजिए, खड़ा कर दीजिए.
थोडं उभं करा हा.
इधर से आ जाइए. And I'll make the child stand. I'll examine the child posteriorly from behind. I'll just expose the posterior superior iliac spines that I've marked, and I'll just ask the child to stand straight. But Sarad Ubira, Sakadi Kalabana. Yeah. I'll ask the child to first stand on the normal limb, sir. Yeah, Payavar Ubira, Langdi kar. Yes. It's a small child who's losing balance. So I'm just holding the hand to stabilize the child. Other than that, we can appreciate that the ASIS on the posterior superior iliac spine on the right side is at a higher level than the left side. Ideally, this is to be examined for 30 seconds. You can see that it is at a higher level. Saradu Bida. Langdikar? You can see that. Kata khali kar. But on this side, when the child is asked to stand on this side, we can see that the other side is sagging down. It's going at a level below. So, Ubira. Very good.
Does she have any flexion deformity? Because when
No,
she's
ma'am.
standing with a lordotic curve.
Ma'am, I have not been, ma'am, I've tried doing the Thomas test, but the child does not have a flexion deformity. In fact, even extension is possible on that.
Because when she was standing, probably because of the laxity or something, the hypotonia of the muscle, but she walks standing with a typical lordotic gait. Do you see any time lordotic attitude in a case of DDH?
Ma'am, sometimes cases of bilateral DDH may only present as, because they may present with the concern of excessive lumbar lordosis.
Yeah, so
because
very
the
true. If
child
you have a
is painless.
bilateral, they will have the lordotic and a duck-like gait. So very important in the bilateral cases. How is her gait?
Gait, ma'am, she walks with a bipedal unassisted Trendelenburg gait with an abductor lurch on the right side.
जरा चालून दाखव, चाल. So why do you say it's a Trendelenburg gait?
Ma'am, because when the child is weight bearing on the affected side, on the right side, the child is leaning the body onto the same side of the.
What about short limb gait? Short limb also they will go to the same side. So
How
short.
can you differentiate short limb gait and a Trendelenburg gait? What two things do you have to look for? You said one thing about the lurching, where the child is tending to lurch. What else?
So the other thing is that the child will try to swing the lower limb away because the abductors are not functioning. The child will it will be almost a swinging motion of the affected side.
So you have to see on which side the pelvis is dropping. Is it dropping on the side of the stance phase limb or the swing phase limb? Okay, so if it is the pelvis is dropping on the side of the swing phase limb, then it is a Trendelenburg. And if it is dropping on the side of the swing stance phase limb, then it is a short limb.
So what is your, any other test, any other examination, or do you conclude, what is your diagnosis?
Ma'am, my diagnosis is that this is a 4-year-old child presenting with an unstable hip, probably due to a developmental dysplasia, disabled with a limp and the parental concerns of a swelling over the right hip.
Here, like we said in short case, because these are associated with certain syndromes, you can have bilateral. So always when you conclude the examination, say the spine, hip, other joints, upper limbs are normal.
Yes.
Any other association or anything over there?
So ma'am, the general examination of the spine of the other limbs showed no abnormality.
Any other differential you want to keep?
Ma'am, I would like to consider the differential of a post-septic sequelae of the right hip, considering the NICU stay and the findings could be similar.
So always when you give the diagnosis, your pathology, the probable etiology, whether they are treated, untreated, and the functional, the chief complaints why they have presented for any functional impairment or cosmetic concerns. So all these things should come in the final diagnosis. So this child is untreated. Many times they are treated partially, given some cast or something or some. So all that also has to be mentioned. So in a long case, everything has to be complete. Your probable diagnosis and the other whatever I said. So now what do you want to do?
Ma'am, I would like to get an X-ray of this child done.
Never say X-ray of the child. Child means what? X-ray of
pardon,
which area, what views, all
I
these
would
things.
like to get an X-ray PBH done, ma'am, for this child. And also, yes, ma'am.
Only PBH
Array.
and never say PBH. Always say
pelvis
full
with both
forms.
hips.
Pelvis with both hips, which views?
So pelvis with both hips in the AP
See,
view.
madam asked you one question. The answer which you gave made us ask you 3 more questions. Instead of that, you should say, I would like to get plain X-rays of this child of pelvis with both hips, anterior, posterior, and frog leg lateral view. Finish. Then we can go to a better question, na?
Yes, sir.
Yeah.
So whenever you are asked any question, give as complete answer and as informative as possible. So that creates a better, I'm sure you know, and you always ask in your OPD also, AP lateral, you write always. But give a thought. It's not necessary that you have to be very prompt in answering. Think for a second and give a complete informative answer. That makes a better impression. So don't say X-ray of child. Child means what? I'm going to do skeletal survey or do everything. No, you're going to see the hip. Whatever you're doing practically in your OPD, the same thing applies here.
So what are you going to ask for?
Sir, X-ray of the pelvis with both hips in the AP view and the frog leg lateral view.
Okay. So do we have that?
What do you expect to see or what will you look for till the time he displays? Start talking.
Ma'am, on the X-rays, I would expect to see the left-sided hip. I will examine first to see what is normal because I expect to see the ossific focus of the femoral head. I'll compare that on the right side and I expect to see an increased medial gap or increased medial gap on the right side. The X-ray probably, the proximal femur has probably migrated up. So I'll look for that. I'll be drawing certain lines on the X-ray, ma'am, to guide my...
Which lines?
Ma'am, I'll be drawing a line joining both the triradiate cartilages called the Hilgenreiner line, and I'll be drawing a perpendicular line to this at the edge of the acetabulum called the Perkins line.
Okay. So where do you expect the head to lie?
Ma'am, in this child, I'll expect to lie in the upper outer quadrant, where the line is on the lateral to the Perkins line and above the Hilgenreiner line.
Okay. Normally, where is it?
Ma'am, normally it's in the lower inner quadrant.
Okay. So first thing is confirm the diagnosis. What you are thinking clinically, first of all, you're going to confirm the diagnosis by whatever lines you said.
This is an anteroposterior radiograph of the pelvis with both hips in a skeletally immature child. We can appreciate the triradiate cartilages here. So the Hilgenreiner line will be drawn joining these two cartilages. The Perkins line will be drawn from the lateral edge of the acetabulum perpendicular to this line. That will be vertically here and here. So on the normal side, we can see that the center of the femur head lies below the Hilgenreiner line and medial to the Perkins line. But on this side, we can see that it probably lies above the Hilgenreiner line. Pardon?
It is line, no?
It is line.
Now you're seeing it.
Because we draw it. Yeah. And lateral to the Perkins line. And also one more thing that we can look for is over the Hilgenreiner line, we can draw a line along the roof of the acetabulum. This is known as the acetabular index. And we can see that it is increased on this side. In acetabular index of more than 30 is pathologic.
So how much is the acetabular index? At what ages?
Sir, at birth it is around 27.5 degrees. By 6 months of age, it's around 23 degrees. And sir, at after 2 years of age, it is below 20 degrees. At any age, sir, if it is over 30 degrees, it's pathologic.
Okay. So how will you draw the acetabular index here?
Sir, I'll draw the Hilgenreiner line, and sir, along the roof of the acetabulum, I'll draw another line. That is the angle I will measure. So this.
So this is a very typical or very bad acetabulum which you are seeing here. On this case, in this side, you can see that it's a nice sharp looking acetabular edge, right? Everyone is appreciating that. In this case, you are seeing something which is very weird. You can have multiple lines which are seen. So what you should always remember, you should have a sclerotic edge to your anterior edge of the acetabulum, and that is where your point of the acetabular index should be, right? So this sclerotic edge what is most important, and that is what you should measure when you are drawing an acetabular index. So what else do you see here?
Sir, I see that there is the formation of something like a pseudoacetabulum, a false acetabulum,
Okay,
and sir, on the
where can you just show the false acetabulum?
so here.
All right.
And sir, on the lateral radiograph, I can appreciate that the femoral head is not congruent with what should have been the acetabulum, with the acetabulum here, but it is again forming a false acetabulum over here.
How is the teardrop? Can you make out where is the teardrop?
Ma'am,
What is the teardrop on the other left
this
side
is
and
the
right side?
teardrop on the left side.
So
and
any
this is
change in the teardrop?
ma'am, the teardrop appears to be ma'am, a little widened on the left side.
Okay.
And
On the
See,
right
so
side.
theoretically, you
right
know all the signs of a dislocated hip, right?
Yes,
So now all of them you have to talk about. What is Shenton's line, whether Shenton's line is broken or no. So all this theoretically, you know, should come fatafat in your answer.
So what I suggest now, what is very easy to do, you start with the pelvis, then you start with go to the femur, and then go to the angles. So then you don't miss anything. So you start with the pelvis. What do you see on the pelvis? You see that the acetabulum is shallow. You see that there is a false acetabulum which is formed. You can see that there is probably some amount of flexion deformity. I can't make out because the obturator foramen may be slightly asymmetric, but that's fine. You can see that there is a widening of the Kohler's teardrop, right? So these are the findings which are seen on the acetabular side or the pelvic side. On the femoral side, what are you seeing? Probably the ossific nucleus is slightly smaller. There is a high riding of the femoral head. You can see that there is a soft tissue shadow of the hip joint also. You can see it's very beautifully seen here, which is going right till the false acetabulum. Can you just point out the soft tissue shadow of the hip? Right, you can see. No, dikha. So you can in fact beautifully see. Oh, sorry. You can beautifully see the capsule which is delineated here, which is going right till the false acetabulum. So this is the false acetabulum here, and the capsule is going beautifully right here. Even on the lateral view, you can see that, appreciate that shadow. All right, and then you go for the various angles. So angles and the lines. So you have the Hilgendreiner line, you have the Perkins line, you have the acetabular index, so that everything becomes complete. All right. So after this also, is your diagnosis confirmed? Is it DDH, or you feel that there is something else also?
sir, after this I would confirm my diagnosis of DDH because
Yeah. I will still, even on table, I will keep that point of a neonatal hip sepsis sequelae in my mind. The reason is that the hip X-ray is not looking, I mean, it's looking something which is extreme. So it's looked like a very extreme dysplasia of the acetabulum, right? With not much of high riding of the femoral head, right? So typically in a DDH, you see a very high riding DDH and high riding hip, and the acetabular index is slowly goes on increasing. Now here it's like a severely increased acetabular index, almost like a vertical acetabulum, and the station of the femoral head is not very high, right? So I'll still keep a differential of neonatal sepsis sequelae when I will probably do a surgery at that time. All right. So quick, sir, what will you do for him, for her?
sir, for her we'll try because she's only 4 years old. We'll try to reduce the hip. We'll do an open reduction for her, and we'll
Why
try.
does your sentence start with because she's 4 years old? Only 4 years old, I will start with open reduction means what?
Ma'am,
You have to reduce the hip. You can't leave it alone. Okay? So your goal is to reduce the hip.
Yes.
Can you do it closed reduction at this age?
No, ma'am.
No. So you will
it
have
will
to
be
offer her
reduction
open
of the hip
reduction.
with a innominate bone osteotomy to get coverage, because I can see that this is a dysplastic acetabulum. And
Okay, so what will you do in open? So in open reduction with what?
with probably a Salter's osteotomy, sir.
Okay.
So open reduction with taking care of all the intra-articular and extra-articular obstacles of reduction, which if the examiner asks you, you should know.
Yes.
Okay, what muscles, extra-articular means your adductor tenotomy, psoas, intra-articular pulvinar pad of fat, in transverse acetabulum, all those things. Okay, so taking care of this summarizes everything. And SOS, femoral shortening and derotation, varus, whatever osteotomy, depending upon, once you have done all those obstacles, how is the stability of the reduction, that will decide whether you're going to do a femoral or acetabular or shortening osteotomy. So taking a call, but looking at the X-ray, you definitely seem that she will require an innominate osteotomy, may require a derotation osteotomy, shortening depending upon how the
tension
reduction
there.
is, how stable or how tight the reduction is.
Yes.
Okay, so principles you have to say. If the examiner then tells you elaborate how you are going to do, then you start with all the incision, what incision, how will you do all the steps. So first answer should be all your principles. So the examiner knows that you know how is your thought process, how you are going to proceed. Okay.
So basically, the possible questions that can come up in relation to the theoretical aspects that she said is, number one, you have to know the types of pelvic osteotomy in and out. Then if you are asked, Madam said about what are the obstacles of reduction. In open reduction, what are the steps that you will have to know. Then what cases are you going to do a femoral osteotomy and what is the nature? So primarily in DDH, unlike in Perthes where you do a varus derotation. Varus is the main component of the osteotomy in Perthes. In DDH, the main component is derotation. You generally don't need to give any varus in case of a DDH. Plus, in Perthes, so that can be the question. What are the differences between a varus derotation osteotomy in a Perthes versus the femoral osteotomy that you do in DDH? So number one is the varus. Number two is, you don't do a GT apophysiodesis in DDH, unlike what you do in Perthes. So these are some of the theoretical questions that you will have to be asked. Standard questions.
You should say, the goal of my treatment is to get a concentric stable reduction of the hip, for which at this child of 4 years, I would offer open reduction and so depending on the stability of femoral and acetabular osteotomy. Okay?
So what is very important to know is that you should not straight away jump to. So in some books, the basic books, which after 3 years, Salter's osteotomy. It is always, first is open reduction. Then you do whatever procedure is required to keep the hip in and make it absolutely stable. If you require a femoral procedure, then a femoral procedure. Again, the direction and the way that femoral procedure is done depends on the position in which the hip stability is obtained. And if required, an acetabular procedure. That acetabular procedure again will not go into the depths of it, but you should know about a few basic osteotomies of pelvis.
Yes.
All right?
Yeah, my question is that will we, like on table we do an open reduction and we get a stable hip. Do we, is an osteotomy, should it be planned for this patient immediately looking at the X-ray, or it's an intra-op decision? Like, should we wait? Like, if you have an open reduction, we do an open reduction, we remove the barriers to the reduction, because the acetabulum development will occur even if the head is stable, and concentric head, if it's given, the acetabular development will still take place. So,
all right. So the decision for doing a acetabular osteotomy is partly pre-op and partly intra-op. In this case, I will not see a scenario where I'll come out without doing an acetabular procedure in this case. A hip, an acetabulum which is almost vertical, extremely shallow acetabulum, I don't see. In fact, I'll have to really think about how exactly to do a good acetabular coverage. If in this case the hip is not so high riding, so I may probably not require to do a femoral shortening. So which means that I'm not going to get a good cortical graft in this case. So I'll probably also consent for doing a fibula graft and see to it that I pack it with pack the acetabulum with a good graft. So coming to the point is that it is an intra-op as well as pre-op decision. In very borderline cases, say 1.5 years or so, in case I get an unstable reduction in adduction, I'll still go ahead and do a pelvic procedure. Though it is said that because of the biological plasticity, the acetabulum does develop. In this case, I don't expect that the acetabular index is going to go from whatever 70 odd to 30 with just biological plasticity. It is going to require some help, right? And I don't see a scenario where the hip is going to remain stable with just a femoral with just an open reduction with or without a femoral osteotomy. It is going to require an acetabular procedure. And at 3.5 or 4, there is not much of biological plasticity. It is going to require a secondary procedure. So it's always important to do it at the same time and come out with a stable hip.